You're listening to IHC's podcast. Today's topic is Culture is Medicine.
Welcome to the IHC Podcast, where culture meets community. I'm your host, Marissa Hemstreet from the Canyonito Band of Navajos, and your communications coordinator with the Indian Health Center of Santa Clara Valley, where we provide medical, dental, counseling, WIC, and prevention services to over 23,000 members, while specializing in the unique healthcare and needs of American Indians and Alaska Natives. Today, for this special episode of the IHC Podcast, we're talking about colorectal cancer screening, and we're here with our special guest today, Luke Day. Go ahead and introduce yourself.
Hi, Marissa. Thank you so much for inviting me to join the podcast today. My name is Luke Day. I'm Oglala Lakota from Pine Ridge Reservation in South Dakota. First, just want to really thank you for all the outstanding work that you and your clinic are doing for the community, and really excited to have the discussion today around colon cancer and colorectal cancer screening.
Yeah, thank you so much. So one of the things I got to learn about you in reading your bio was that a little bit about your journey. So from Yale to Stanford, and now pursuing an MBA at Wharton was remarkable. Looking back, were there any turning points or mentors that helped guide you down this path?
I always have to reflect back on where I came from. Where I'm at today, if you would ask me when I was a young kid, I don't think I would be at this place. I'm just really thrilled and honored to be at every stage that I've gone through in terms of my education and where I'm at with my work. Came from very humble beginnings. I grew up in Southern California, a really small rural town, and then spent most of my summers on Pine Ridge Reservation being raised by my great-grandmother and grandmother. So very much had a strong matriarchal presence in my life growing up. And they are the ones, I think, who've influenced me the most and who really valued community education and collaboration. And I think where I'm at today is really through the learnings from them, from the time they gave me, from really just the support and just sort of pushing me and asking me to do more and to sort of continue to do the best that I potentially could. And so I think it's from those beginnings that I always reflect back on in terms of where I've been able to reach today.
Awesome. That even took care of my second question about, as someone from the Oglala Lakota Nation, how has your community shaped your own understanding of health equity? And I feel like you already got that one.
Yeah. Well, and it's a great question. And I think all of us probably have stories, but, one of the things I vividly remember is spending time as a young kid traveling with relatives and other community members to clinics on Pine Ridge Indian Reservation to receive healthcare. And many times we would travel many hours just to go see a physician and have to wait there as well. And even as a young kid, I could see the frustration and the barriers and the obstacles that my family and my community face just to get to healthcare, and even have more barriers once they got to the clinic itself. And so I knew at a young age, I didn't know it was health equity. I didn't know it was called disparities. But as a kid, I knew it wasn't right. And I knew it was something that we should work on trying to change. And that's really kind of how I thought about getting into healthcare. And again, as I said, it was really my family who taught me about community, and that working together as a community is how we make each other stronger. And so that's how I sort of went into healthcare, thinking about how we do it as a team, how we work collaboratively, how we think about things as a collective in terms of trying to solve the really large problems that face all of us.
Yeah, and unfortunately, that's not something that you don't see a lot of on reservations throughout the U.S. Even in my home reservation, Tahajli, to get to the hospital, it's like an hour-long wait. And they had a recent shutdown of one of our emergency care centers that was like 15 minutes away from Tahajli, which is in Acoma area. And then so now the only hospital that we can go to is the one in Albuquerque. And if there's traffic on the 66, good luck. You're going to get there in like 2 hours, and you never know if someone has like an emergency where they need to be there sooner. So, thank you for helping tackle this issue and bringing attention to it.
You raise a really good point in that, many times when we think about healthcare and how we can make a difference is we sort of focus on sort of what's right in front of us. But I think as you're pointing out, we have to take a step back and really look at how much the surrounding environment and how much the community around us and all these external forces really impacts and drives a lot of our healthcare that I think we as practitioners and people who are at the front lines may not necessarily see or realize, but need to be aware of it and really sort of realize where patients are coming from many times.
Yeah, and there's a reason that we're doing this work. So thank you so much for that. And through your bio, I was also able to see that you're the first person to ever hold the role of System Chief Medical Officer at UCSF Health. What was the moment like for you personally, and how are you bringing your values into shaping this new position?
I had a lot of feelings and emotions when I was offered the role and in stepping into it. Very excited, nervous, um, maybe apprehensive a little bit in terms of because being an inaugural role, really not knowing what I was sort of going to be moving forward into. But that's kind of the excitement of the role itself, and just honored and humbled. Being able to step into this role in such a fantastic institution and being selected for it just meant so much to me. My leadership is really shaped by one is I try to reflect the values that I would like my team and my frontline team to really show as well. That's really around how do we be transparent? How do we collaborate? How do we be present where we're at? Treating one another with empathy and respect, but really thinking about equity and really looking at everything through an equity lens in terms of also like how can we do things better? So I always like to say I'm a continuous learner or always wanting to try to refine things. And so I'm always asking my teams and people that I'm working with in terms of how can we do things better? How can we remove friction from our patients and from our staff's encounter with the healthcare system, knowing that there's so many barriers there. I think, one of the things I've been trying to do and one of my priorities in my first year in this role is really thinking about how do we create more psychological safety across the entire healthcare spectrum for our patients and for our staff. Really trying to work on how do we empower the voices of both, really uplift those voices and those perspectives and involve them in kind of the decision making and trying to learn from them in terms of, how we might be able to solve some of our daily problems that we're encountering.
Yeah, that sounds like a prime example of just good leadership. So I'm happy to say I feel like your team is well equipped with you at the helm.
Thank you very much.
And that's not so much something that we hear so much about, like you were saying, like the mental health, perspective and making sure that not only the patients are taken care of, but even like the providers as well.
Yeah, it's, I always like to say healthcare is a team sport. I think many times we think about it from an individual perspective, but it's really the entire collective whole. So it's providers, nurses, technicians, pharmacists, it's everyone is really providing care for patients. And so how do we all work together in terms of communication, problem solving, really enabling and trying to help the patient, because that's really why all of us are really in healthcare, is how do we help improve the lives of our patients that come to us?
Yeah, not just improving or helping take care of the symptom, but like getting to the root of the problem. That's really good to hear.
Absolutely.
Yeah. So you've dedicated a lot of your career to improving patient safety and quality of care, just like we touched on. Was there a specific patient or experience that first sparked that passion for you?
I think there are many instances that have sparked that passion and I think continued it. But I think one of the earliest memories I have was when I was a medical student and witnessed an adverse event when I was doing one of my rotations. And when you got down to it and really looked at it, it came down to communication and really just sort of a lack or sort of miscommunication amongst the team, but also some of the other interdisciplinary teams. And so I realized at that point that really, within the healthcare span itself, it's like we have to sort of really think about it collectively as a team. How do we sort of share information? How do we learn from each other? How do we work together rather than in silos? And so that's one of the things I've always dedicated myself in terms of sort of quality, safety, and patient and staff experience is really, as we were just chatting about, thinking of things as, the entire collective, the whole person, the whole patient, the whole team itself, and really trying to improve all of those processes.
Yeah. And through your leadership, how have you been able to balance your leadership, clinical work, and cultural identity? Sometimes I know that can be challenging as a fellow Indigenous person in healthcare. What helps you stay grounded and inspired when you're facing those difficult moments?
Yeah, no, and I think all of us, here can relate to it is that, there are very few American Indian Alaska Natives in medicine. Just as a statistic, I'm a gastroenterologist. There are about 17,000 gastroenterologists in the US, and there are, I think, 10 that identify as Native. And so it just gives you a sense of really the lack of representation of our community within healthcare, and that's just providers. And so we haven't even talked about nursing and other healthcare specialties. And so that's one of the things when I was growing up was that I didn't really see a lot of Native physicians, and it wasn't until I was in college and then in medical school. And so I always knew that I really wanted to work passionately to really increase that and really sort of help underserved communities enter the healthcare sphere and the healthcare space. And so I've always committed and dedicated my work to that. I think there are many ways that I stay grounded. One, at work, it's really always coming back to the patients and the families that I take care of. And so many times, I will go chat with the patients on the wards or talk to my patients when I'm in clinic to really, I think, help ground me and really sort of reemphasizes why I went into medicine. I think externally, it's really my family. So my husband and my parents and my in-laws are just really strong forces. And then really my community. So, and I really mean my Native community. And so both on the reservation, but also through the Association of American Indian Physicians, which is the only Native physician group in the country, but is just a really phenomenal, small, but really close, tight-knit group that has really just supported me through my entire career and my entire journey in medicine. And they've gotten through me through some very difficult times. And so I think it's really just having that support and that network that has been really impactful.
Yeah, and I can relate, especially like you were saying, it's not just that with the statistic wise with providers, it's all across the board in healthcare. So I recently got my bachelor's in kinesiology. I'm a pre-physical therapy student, going to grad school next year.
Congratulations.
Thank you. And that was one of the things I got to see too, even in the realm of physical therapy, that Native Americans, American Indians, Alaska Natives only make up 1.6% of physical therapists across the US. And I was just like, whoa, you see the whole 100%, you see the teeny tiny 1.6%, and you're just like, oh my goodness, how am I going to get there if I don't see other folks who look like me there? But you got to be that representation. And thank you for being that representation for gastroenterologists and, making, younger Native students feel like that is a future that is possible for them and attainable. And they see somebody in that field and not only just, being there, but thriving and, being a person in leadership. So thank you so much for being that representative. I'm getting shaky. Oh my goodness.
Well, and I think what you're saying, which is perfect, is that, it really comes down to like mentors, like people who are in your life who you can look up to, who help support you, who help guide you. And so as we all have been talking about, like, I wouldn't be where I'm at today without mentors in my life. And so like, to me, giving back and really trying to support people through their journey and knowing how hard healthcare and medicine can be is just really a joy. And just like, I couldn't think of anything else that I would want to do.
Yeah, thank you so much. And for the listeners, for those young Natives out there listening, achieving these goals is 100% possible as long as you have the will to do it. And if you need some resources, you can go ahead and reach out to Indian Health Center. You can check us out at indianhealthcenter.org. You can email me directly at marketing@ihcscv.org to get some resources for whichever your endeavor it is in regards to education. Yeah, thank you very much.
And if I could say one more thing on that, we've talked a little bit about my background and kind of the work that I do today. I will say that to get where I'm at today, I was told no a lot. I was told that I couldn't do it. I had a lot of failures along the way. And so just to all the listeners out there that well, there might be challenges and obstacles, just don't ever give up. I think, you'll hear more, but you'll hear no more than you might hear yes, but just persevere. Like if it's really something you are passionate about, regardless of what it is, you should just continue to do it and move forward on it because it's the right thing for you. And what's right for your heart and what right for you is going to be for the rest of your life. And so I would just sort of, as we're closing out this particular topic, I think that's one of the things I would impart the most around sort of one's education and their journey on it.
Thank you. Those are inspiring words. I can't wait to see that little quote on your title card. Thank you so much. And with this episode, it's a special one because I'm not only the host, but we got our patient navigator team also here to ask you questions. So I will be muting myself. And Harleen, you can go ahead and lead us off on the CRC related question.
Hello, my name is Harleen. I'm the patient navigator for the colorectal cancer screening program at IHC. It was great to hear about your journey in medicine, and I would love to learn more about the work that you've done in colorectal cancer screening. So I was wondering if you could share what your experience has been like working with both the general population and the AIAN communities around CRC screening.
Yeah, no, that's a wonderful question. Colorectal cancer screening, we know, is one of the most impactful things that can reduce colorectal cancer in our communities. Colorectal cancer is either the second or third most common cancer that affects all Americans, regardless of race. It's also the second or third most common cancer that we pass away from as well, too, in the US. So not only is it common, it's incredibly deadly. But I always like to say colorectal cancer screening saves lives. And so it's really important that we provide the education and the tools and let people know about it. And so just really want to celebrate this podcast for raising awareness to it. I think every time that I have worked with varying communities around colorectal cancer screening is really trying to meet them where they're at. Some of the things we've talked about is barriers that our patients face in trying just to get to the physician or to the clinic. And so really just thinking about that from the lens of colorectal cancer screening. It requires you to do a test, whether it's a fecal stool test or an endoscopy. There's parts of that that require patient accessibility to it. There's other steps that are needed to be taken for it. And so I think it's really just trying to go out, meeting patients where they are, providing education, I think really working with the communities that you're serving. So I think it's really understanding their understanding of colon cancer, really sort of, I think what I like to say is uncovering the why. So why should they want to do screening? Why is it important? And then really just thinking and working with them about interventions to really try to help increase screening uptake.
Thank you for sharing that. I definitely agree. I would like to pass it on to Nick. He has follow-up questions.
Hi, everyone. My name is Nick Campbell, and I use he, him pronouns. I'm an enrolled tribal member of the Cherokee Nation in Oklahoma. I was born and raised in the city of San Francisco, but I'm also very connected to my Cherokee family and friends who live in Oklahoma and spent a lot of time there growing up. I am a junior studying biology at Stanford University, and I volunteer as a patient navigator with the CRC program at the Indian Health Center of Santa Clara Valley. Thank you so much for sharing all that you have. I think your story is so inspiring, and I really learned a lot from you. My question is a little bit of I guess, a follow-up or related to the last question. But we know that colorectal cancer screening rates are significantly lower among American Indian and Alaska Native populations. And so I guess we were just wondering, like, what do you think some of the biggest obstacles and challenges are for our community specifically? And why do you think those barriers persist? And then also, in the general population, like what are the differences and barriers that they face as well?
Yeah, no. So, unfortunately, colorectal cancer screening rates amongst the Native community is incredibly low. It's one of the lowest compared to all other racial groups in the United States. I think it kind of hovers at around 58 to 60%. So definitely, that speaks to a lot of opportunity to try to improve it and try to increase those rates. I think there's no one thing that really explains why the rates are lower compared to other communities. A couple of things. One potentially to consider is just access to healthcare. So, we talked about that at the beginning of the podcast is lack of access to clinics or nearby clinics, maybe not having transportation available to make those appointments, or the inability to maybe take off time from work or household activities. I think the other things to think about potentially for colorectal cancer screening is just many communities have a fear of being diagnosed with cancer. And so I think that also speaks to people's concerns, and we see that across many communities. I think, and all of us would agree, I think on this podcast is that there's a lot of mistrust of the healthcare system by American Indians, Alaska Natives. Not only has it been sort of centuries of broken promises between the federal government delivering healthcare to our communities, but there's been a lot of sort of, stories and poor experiences that our communities have faced and encountered over the years within healthcare. And so I think that mistrust of the healthcare system is something that we as a country really need to work on and overcome, not just within the Native community, but many other communities who've also faced the same challenges. And so I think it's really multiple things. It's sort of social drivers of health. I think it's sort of this concern and mistrust of the overall U.S. healthcare system. And then it's really this fear of having a diagnosis of colorectal cancer. And so I think a lot of this is really how do we rebuild that trust and also provide more education within our community.
Definitely. And I think, I guess building off on that too, like one thing that I've seen is really important is having, people like you, people like us that are Native professionals in the health career. So it's definitely like the work that you're doing is so important.
Yeah, I couldn't agree with you more. Yeah, it's absolutely right. And I think that's one of the things that, a lot of the work that me, my colleagues, and other people within organizations that I work with is, again, really when we want to increase colon cancer screening, is really just going out to the communities, to the frontline leaders, elders, healthcare leaders within those areas, and talking to them and understanding, where they're at, what would work, really trying to partner with them and understand that we're there for the long term. And then sort of building upon that about the education and trying to sort of help make it much more accessible to them.
Yeah. Thank you so much for that. I want to pass it to Jamie. I know she has some more questions.
I'm Jamie Lee. I work as a lead patient navigator for our colorectal cancer and diabetes management program here at Indian Health Center. In addition to that, I work as a medical translator. Here is our final question, the one that I personally wanted to ask the most. How can healthcare systems or community health center like us better improve CRC screening access and outcomes?
Yeah, no, and one, I want to start by really thanking all of you who are patient navigators at the clinic. That is just such incredibly impactful work for our community. We know that patient navigators who work with our patients, who meet our patients, who kind of talk to them about the healthcare system, that is one of the most powerful things and one of the biggest drivers to really improve overall healthcare. And whether it's screening, going to appointments, following up on tests, like we know that patient navigators are really critical to that piece. And so I'm a big believer and a big supporter of patient navigators. And I think that's one of the key components of increasing colorectal cancer screening amongst Native Americans. The way I like to think about how we would increase screening is very much sort of a stepwise approach. And I think about it as sort of the screening journey for an American Indian Alaska Native patient. Kind of at the building or the beginning of that journey and the foundation of it is really, as we talked about a little bit earlier, is education. So really, again, going out to our community, developing educational materials that patients and natives are familiar with, are in their languages, are in ways of which they understand in the way that would reach them by the best modalities. And so really starting with that educational piece and really partnering with the communities. The next piece is then really how do we sort of build on that education and remind the communities that they need screening. So as you all know, colorectal cancer screening, there are many ways that you can be screened and it can happen at different time periods, whether it's every year or every 10 years. We really need to sort of take that reminder off the patient's plate and really sort of just push it out to them. And so we know that things such as leveraging digital technology, so even simple text reminders can actually help increase screening uptake. Then I think it's sort of really about what I call community outreach. And so really going in and meeting our patients and making the test accessible to them there, as opposed to having them come into the clinics to get the test. So do you mail the fecal blood test to them? Do you have sort of mobile colonoscopy units that can actually go to communities and do the screening? So really meeting patients there. And then the last piece is really, I think, on the workforce, which is really increasing Native representation in healthcare. How do we leverage other healthcare providers besides physicians doing the screening? So we know that advanced practice providers can definitely deliver colorectal cancer screening, specifically endoscopy, has really been impactful in increased screening rates in Alaska and among Alaska Natives, but also just empowering staff members to provide the screening test. So handing out the fecal test when they come in for their appointments. And I think really just embedded throughout that journey is, again, what you all are doing is really this powerful work of patient navigators, really working with patients and kind of holding their hand as they go through this journey, which can be somewhat really concerning and people may have lots of questions, but having someone who understands them, who maybe has been through it or who's helped other patients, really providing that information and answering those questions, I think is going to really increase rates significantly, and also have people adhere to it and continue to follow up with it.
Thank you for such an in-depth answer and really kind of giving us like a role model for IHC to follow and implement. That would be so exciting. One of the things that IHC got to do for CRC Awareness Month, which is March for our listeners, we got to do tabling, and we went site to site. We shared a little bit of information about the different types of testing that folks can do for CRC screening. We also handed out some freebies because, you know, folks don't really want to come talk to you at a table for fun about their colon and health. So we got to hand out like water bottles and amongst other goodies. And I really think the whole team, because they were all there outreaching with me. And another person that got to outreach with us was Valerie Montero. She's our outreach coordinator within the Intertribal Resources Department. So I want to give her a quick shout out. But yeah, do you have any words of wisdom for us? It can be in regards to colorectal screening health, or it can be in regards to, you know, being a physician, being American Indian and health, you know, whichever parting words you'd like to give us.
Maybe I'll touch on each of them. I think, you know, for colorectal cancer screening, what I tell people is the best test is the one that gets done. So we really just need to meet our patients where they're at, answer their questions, and just really try to make the test the most accessible to them. So it's really just giving them options of the test and making sure that they can follow through on the test. I think in terms of, I think the broader topic of being American Indian, Alaska Native in healthcare, I am so grateful for where I'm at right now. And it just warms my heart to see so many of you who are doing the same work and doing such wonderful jobs. And so it just inspires me to have conversations like this and to see all of us really working hard to improve the lives of our community. And so just to all your listeners out there, you're not alone. Definitely feel free to reach out to me, how we can sort of help support you in your journey. Because as I said earlier, it's really through mentors and coaches who helped me to get where I'm at today. And so I think we all just really need to help and support one another.
And Jamie, can you share a little bit about the story behind launching our colorectal cancer screening program? Since this IHC podcast episode is in honor of Colorectal Cancer Awareness Month, even though that was this past March, we're getting together today to talk about it. Can you share the story behind launching our colorectal cancer screening program?
We currently have 3 chronic health management programs for hypertension, diabetes, and colorectal cancer. Prior to colorectal cancer program, our hypertension and diabetes programs were already up and running, reaching patients whose providers simply didn't have the time during office visit to cover every preventative care recommendation. When COVID-19 drove our colorectal cancer screening rates down, despite CRC being one of the most straightforward and universally recommended cancer screens, it became clear that we needed a dedicated program. With grant funding, we started the colorectal cancer program. In July 2024, Herlene joined as our patient navigator, and Nick came on board as a weekly volunteer in the end of December 2024. At the Ocean Learning Forum, we discovered Exact Science and their Cologuard outreach model through another FQHC's presentation. So our population health director, Daniela, reached out and secured a partnership. Exact Science now manages Cologuard kit distribution, statistic tracking, and multilingual support lines for eligible patients. Everyone else is offered the fit kit by us.
Since day one, how has the program improved CRC screening rates and patient outcomes?
Prior to launching our CRC program, provider-driven outreach resulted in a 35.5 overall screening rate, with just 25% of American Indian and Alaska Native patients screened. After 1 year with a dedicated program in place, overall screening climbed to 48% and AIAN screening rose to 39%. And we are working towards the Healthy People 2030 target, which is a set of goals established by U.S. Department of Health and Human Services to raise the proportion of adults who receive CRC screening to 74% based on the most recent guidelines.
Okay, thank you. And Harleen, can you walk us through the typical workflow of the CRC navigation program, from identifying eligible patients to the education and follow-up?
Yeah, so we initially start with reviewing a patient's chart, seeing if they are up to date with their colorectal cancer screening or if they need to complete their colorectal cancer screening. And then we check their insurance, and according to their insurance, we'll go ahead and send a patient either a FIT kit or a Cologuard kit, which are both stool blood tests. And we'll go ahead and place the order, and then the Exact Science team will send the Cologuard to the patient, and then the IHC CRC team will go ahead and send the FIT kit to the patient. And then following that, we'll give the patient a couple of weeks to get a chance to complete the test and get the test. And then we'll follow up with the patient and ask them if they received the test, both the Cologuard or the FIT kit. And then we'll ask them if they had a chance to complete it. This is also a great opportunity for us to ask the patient if they have any questions or concerns about the test. Some questions that patients have are like, how do I complete this test? What is the purpose of colorectal cancer screening? And so it really helps us address that and help patients complete their testing.
Awesome. Thank you very much, Harleen. So can you share a story, a standout patient story that illustrates how the CRC program has improved someone's health?
Yes, so there was a patient who I contacted after a couple of outreach attempts. I was able to connect with them, and I asked them if they received the Cologuard test and if they had a chance to complete it. And they told me they did receive it, but that they didn't want to complete the test because they were informed by a family member that the test was an invasive testing for colorectal cancer screening. And so they didn't feel comfortable doing that type of testing for the colorectal cancer screening. And so I informed them that this test was not an invasive method of colorectal cancer screening, and that you can complete this test at home, and it's just going to require a sample of their stool, and that they can just do that at home from the comfort of their house and send it back. And I also informed them the importance of colorectal cancer screening and how it detects colon issues early so that they can get any treatment if they need before it gets serious. And they agreed. And so that was really great. And it really highlighted how our outreach allowed me to address a patient who may not have completed the testing if due to the possible misconceptions that they might have had.
Well, thank you very much. And Nick, can you explain what colorectal cancer screening involves and why it's so essential?
Sure. First, I just want to take a second and say that I'm so happy to be on this podcast today and grateful for the opportunity to volunteer at the center and work with patients. I've learned so much about colorectal cancer and CRC screening through this opportunity, and I'm just really honored to share what I've learned with you all. One of the big things I've learned is that colorectal cancer is deadly, but it's also preventable. According to the American Cancer Society, it's actually the second most common cause of cancer deaths. But at the same time, it's one of the most preventable cancers. And I think that's because of the natural history of colon cancer, where a majority of colorectal cancers start out as small polyps, which are small cancerous growths in the colon, which then progress to become cancers. And if we can take them out, then we can essentially stop cancer in its tracks. And this is a unique feature of CRC cancer screening because most cancer screening that we have today only serves to detect cancer once it's actually cancer. And CRC screening can actually prevent it from happening in the first place. And I think that's really powerful and a pretty remarkable thing. And also something that I think a lot of people don't really know about colorectal cancer screening. Having said that, CRC screening also finds small cancers before they have a chance to spread to the rest of the body. For the general population, cancer deaths from colorectal cancer have been declining, probably in large part due to success in CRC screening. But there are definite health disparities with certain groups having lower screening and higher mortality than the general population. And one of these groups in specific are American Indians and Alaska Natives, who have some of the lowest screening rates and highest colorectal cancer mortality rates of any other ethnic or racial group. And we'll go over some of the possible reasons for that, but right now I just thought we could go over some of maybe the specifics of screening. So a person with the average risk should start screening at the age of 45. Guidelines changed actually in 2021, where they used to be that it should start at 50, but because of an increase in the younger population getting colon cancer, that recommendation changed to 45. And I think that's something that a lot of people aren't aware of. And we actually see that the lowest screening rates are for people in the ages between 45 and 55. So screening can basically be done in one of two ways. Either you get a colonoscopy or you do an at-home stool sample based test. And I think, it's kind of important to realize that a lot of people don't know that these at-home tests are actual options for CRC screening. Sure. So here's a table that kind of just outlines some of the different screening methods, their advantages, disadvantages, and how often you are recommended to do these tests. So the first one is the colonoscopy, which is kind of considered the gold standard of colorectal cancer screening. And this is where they take a tube with a camera and they put it inside the colon, and you can look through the entire colon for these small cancers and precancerous polyps. This test is recommended every 10 years. And one of the main advantages is that this is the most sensitive test for both polyps and cancer and can remove these precancerous polyps. Some of the disadvantages are it's the most invasive test. It's the most expensive, and these patients may need a lot of support in getting a colonoscopy because it often involves a lot of time in scheduling. They have to remember to go and find transportation and get away from work to do it. So supporting people is a really big deal for colonoscopy. The next two tests are these at-home stool-based tests that Harleen mentioned earlier, and that is the FIT test and the Cologuard test. These tests you do once every year for the FIT test, once every 3 years is the recommendation for the Cologuard test. And one of the main advantages of these tests is that they're at home, they're not super invasive, and they're pretty quick. But some of the disadvantages are they're less sensitive, and they can have these false positive results and false negative results. And if you do get a positive result from either the FIT test or the Cologuard test, you'll then have to schedule a colonoscopy to remove the polyps and see if you have cancerous growth. And then the final test is this sigmoidoscopy, which is a procedure similar to the colonoscopy, where they look at the left side of the colon, where most of these cancerous and precancerous polyps develop. And this test is recommended like once every 5 years, with the FIT tests recommended in the years in between.
Thank you so much for listening. Don't forget to rate, review, and subscribe. If you like our content, check out our social media. Our handle is @IHC San Jose.